It says start. Okay, good. So now we're recording. All right. So hello, everybody. So here's what we're going to
It
do.
just says I was signed.
Your what?
So my thing just said it was signed out. That's so frustrating. Okay, there you are. It's worried.
Okay, Susie, you're fine. Take a deep breath. Everybody, take a deep breath. I know that doing this is like nerve-wracking for everybody. Okay, and I feel nerve-wracking today too because because of my computer stuff. But here we all are. Okay, and here's how we're going to do these. Spend the next 2 hours. Okay, I want to tell you just a tiny bit about who I am and how we're going to do this. And just do real quick introductions, real quick. And then each of you is going to, okay, now what is this? So Susie, are you here twice?
Actually, I am, because the other ones, I'm on another laptop, my Apple. And I'm not pulled up with my PowerPoint on that one yet, but I can be. It's just that the my other laptop, my normal, whatever you call it, laptop that's not an Apple, just kind of stopped. Said I'm signed out.
Okay.
So
Well, that's
I had
okay.
a backup plan.
Okay, so you're back on,
Okay,
and we'll just.
I'm sorry, I have to go find my PowerPoint.
Okay. Well, why don't you
this one
quietly do that, and I'll chatter away a little bit here, okay? Because I know you can multitask.
Okay.
Even though people say you can't multitask, I don't happen to believe that. Yeah. So each of you will do your presentations, okay? And they'll take maximum 7 minutes, and we won't really talk about them afterwards. I'll make some little comment, but I mean immediately afterwards, just so that each of you can go through doing them. So that'll take about half hour, 35 minutes, okay? And then we'll take a 2-minute break, and you can, run to the bathroom, get a glass of wine, a margarita, whatever, just to really relax. And then we're going to talk. We have about an hour that we can talk about, about what you learned in the whole business of advanced practice nursing, just together. So that's how we're going to do this. So my name is Catherine Schrag, and I've been on faculty for Frontier for probably 13 years, I would guess by now. I'm a CNM. I'm also an FNP, although most of my professional work has been as a midwife, and most of it has been in a birth center setting. I also I do some teaching for the American Association of Birth Centers. I teach there how to start a birth center workshop. So some of you that are for the CNEP students, you all at some point go to that workshop. I teach half of them. So you may have met me. Hi again if you did. I was a regional clinical faculty for midwifery and women's health for the West Southwest for a dozen years. I've just quit doing that, and now I'm semi-retired. But I wanted to stay involved with Frontier, and so the only course I'm teaching in is this course. I'll tell you after you do your presentations. I'll tell you a little bit more about my personal business of advanced practice nursing story. So when you do your presentations, as you're presenting, we won't see your face. Okay, the screen only shares one thing. So that's good news for you. So if you were really doing this in real life, not only would you be doing your presentation, but people would be watching your body language and how how you're dressed and how you're fidgeting and all that sort of stuff. So in this, you don't have to do that. So that's a nice piece. I will time you, and if you go over 7 minutes, you saw in the rubric, you get decreased points. So hopefully you've all practiced and you're not going to go over 7 minutes. And if any of you get bumped off for anything, just text or Google chat, however you do that. Adam Caudill, Caudill. So he's the tech guy. He's on standby in case any of us have any problems. Okay. So if you just magically disappear. Now, if I magically disappear, I was telling some of the people who checked on earlier that my internet provider is having bandwidth problems, and in the evenings there's problems. It's not evening time here. I think we're going to be fine. I met with the RIT people earlier and said, "Is there a workaround? You know, could I at least call in?" But there doesn't seem to be a way, because these are private hangout recordings. Nobody can join in unless I invite them. But if I get kicked off the internet, I can't invite them. So let's just, you know, pray for good internet, because I know the last thing in the world you want to do is do this all over again. So we'll deal with that if it happens, but I don't think it's going to happen.
Can I ask a question?
What else? Yes.
So say I'm in the middle of my presentation and I get booted off and I somehow find my way back to you guys or whatever. Does our timer restart and we just start all over, or how would that work?
Yes, we would just start over.
Okay.
Right.
Okay.
Right. And if I disappear, I mean, this is weird. I've been teaching this course, you know, for a couple years since it started. So I've never had this conversation with anybody, because I've never had this internet problem before. But if I do disappear, I am recording it. And so I asked Adam, and he's going to try and find out. I said, if it's recording and you guys are still in the session, does it continue to record? And he said he assumes so, but he's not sure. So if I disappear, do your presentations, all of you. Just go in the order you came in on, get them done, and I'll be in touch with you to figure out what we're going to do about it. But
could you record if you disappear?
He doesn't know.
Oh.
I don't know.
Okay.
Nobody knows. So you would just get to practice it one more time. It's not going to happen. It's going to be fine. All right. Don't even worry about it. But I was just hoping to have you know, it's always good to have plan B, right? So I thought I was hoping to have a good plan B, but I don't have a good plan B. Okay. One last thing before you guys start doing your presentations. So I do want to say that I recognize the challenge of putting together into a 5, 6, 7 minute spiel what took you all many hours to create. But this is kind of the way it happens in real life. You know, I suspect that all of you at some point in your life will have a short opportunity to make a presentation, to make your case for doing something, even if it's just to hire you to get a job. You know, and if you can articulately, persuasively, succinctly, professionally get their attention, then it'll take lots longer than 5 or 6 minutes. Then they'll say, "Oh yeah, I'm interested. So tell me more about this, or tell me more about that." So this is learning to sell yourself, you know. And as nurses, I think more than some professions, we're not so good about promoting ourselves. So this is a safe place to practice doing this. All right. So I am confident that at some point in your life you will be grateful that you did this, that it will be a helpful exercise. And then the last thing I want to say is that, so I will be the faculty that grades you on this. We are recording it, and so I'll go back and I'll listen to it again and go through the rubric and see how, you know, if you, you know, give you the official grade. I'm not going to be like grading you while you're talking now. And then I'll also grade and give you feedback on the budget. And I'll get all that done within the next 3 or 4 days. So you'll hear from me about both of those, and then you will be done with this assignment, which is great. Okay. Before we do presentations, real quick, let's go back around the room. We were just starting to at least find out where people were from before you joined us, Susie. And we're going to have people present in the order that they came on. So Casey was the first person to come on. So Casey, we learned that, okay, you're not in Chicago. Oh, St. Louis.
Yes.
Yes. Yeah. Okay, so that you're in St. Louis, and what are you in the nurse practitioner midwifery program? Are you a DNP student? Some of the students in this class are DNP students. So tell us real quick
Yeah, so I'm in the nurse practitioner track, so I'm going for my FNP.
Okay, all right. And you started your clinicals.
Yes, I'm actually almost
Yeah, okay.
done.
Almost done. Oh, congratulations.
Yes, thank you. I'm happy about that.
I bet. All right. All right. How about Gab?
So I'm the one from Chicago, and I am a pediatric nurse practitioner already, and I am in the DNP track.
Aha. Okay. Oh, great. Okay. So you have worked a few years as a PNP?
That is correct.
Okay. Oh, great. We're going to draw on you, your real life experience as we talk. So that's interesting. Okay. Great. And then let's see, Diane.
Yes, I am in the CNAP program.
Okay.
And I'm doing my clinicals in Albany, Georgia. I'm about halfway done at this point, and I've gotten about 23 deliveries.
Right.
So doing pretty good. I missed one today though, preparing for this a little bit, but
yeah. Oh, that's a little bit of a heartbreak, you know.
Yeah.
Yeah. It's not like missing one of your annual exam wellness visits for the NP. It's a big deal to miss a birth. Yeah. All right. Okay. And then Rachel.
I am currently living in Dallas, Texas. I am in the Postmasters DNP program, and I'm currently working in a hospital setting doing full scope midwifery.
Right. Okay. So you're a CNM, you're working as a midwife, and you're coming back and getting your DNP.
Right.
Great. Okay. CNM to DNP. All right. Excellent. And
how
then
long did you wait between getting your CNM and your DNP?
I graduated in 2011.
Okay. Okay. Just curious.
Good for you.
Yeah. Okay, Susie, where are you and what are you doing?
I'm in Phoenix, Arizona. I've been a labor and delivery nurse for decades, and I decided when I grew up that I wanted to become a family nurse practitioner and serve missions.
Interesting. So you want to do international work?
Not necessarily international work. Actually, my PowerPoint is about a subject that's very dear to my heart. So,
okay, we'll find out. All right. Well, I was just in Phoenix yesterday. We could have had coffee. So okay.
Oh, yeah, we could.
I live in Patagonia, which is a little town south of Tucson, tiny little town south of Tucson. So we got two Arizona people. It's hot there today, right? Like 80 degrees or something?
I have no clue. I have not stepped foot outside. Are you kidding? I've been too busy.
Right.
But the house is cold.
The
house is cold.
Nice cool off. Yeah. Okay, so let's everybody go ahead and mute except for Casey, who's going to present. And I'm not going to start timing you until you're ready to go. So Casey, well, I'm going to get the timer up while you guys, everybody except Casey, mute. Casey, you screen share, and then when you're ready, we'll start.
Okay, can you guys see it okay?
We can see it.
Perfect. All right, I am ready.
Okay.
Okay, so for my practice, I focused on the downtown St. Louis area. That's right around where I live and work, so kind of an area that I'm familiar with and really like. This is some background information about the city of St. Louis. So this is the data that I used when estimating patient visits in my practice. The current population is about 318,000, and it's pretty much an even split between Caucasian and African Americans in the city. The median household income is about $53,000 a year, and the city ranks 111th of 115 Missouri counties. So not great, obviously could use some improvement there. These are sort of some of the consequences of the demographics in the area. With the limited income of a lot of people that live here, food choices are typically a little bit unhealthy, and processed food items that are less expensive and more convenient are really common. It also lacks access to fitness centers, grocery stores, and health food stores, and is mostly full of convenient marts and fast food. So the combination of unhealthy eating and that lack of exercise, obviously a huge contributor to the high rates of obesity in our area. And then the high stress levels are likely related to the limited income and living in and around dangerous neighborhoods. We do have a lot of violent crime in our area, unfortunately. So studies of the city indicate a high rate of premature birth, which is currently at 18.2%, as opposed to the Missouri average, which is 12.7%. Studies also show that there's no real lack of prenatal care and that women are going to those prenatal visits as they're supposed to. So that kind of leads us to believe there's a gap somewhere else. And there are other factors like poor diet or high stress that's prevalent that could be contributing to that. It's no secret that St. Louis has one of the highest STD rates in the country, which reflects here is showing that there are 1,297 per 100,000 people, which is almost 10 times that of the Missouri average. And then the obesity rate in St. Louis City is 7% higher, and violent crime here is over 30 times that of the Missouri average as well. So this is the mission statement for my practice, and I'll just kind of go over the greatest points here, but to identify the present needs in our community and to prevent them instead of treating them, to educate the community from a young age, to instill good health habits and behaviors, and then to present pregnant patients and at-risk youth with a healthy lifestyle so that they can use in the future to make healthy choices. The practice that I'm proposing is a nonprofit practice called Care for You in the Lou. It's a new practice that's also going to implement in-school programs. I chose a nonprofit organization for a couple of reasons. There are grants available for nonprofit organizations here that are striving to provide services for high-risk or low-income areas. And then they're exempt from taxes, which is great. It leads to availability of more funds for patients and services since we try to get them at a lower cost. And then they also require a community health needs assessment, which I thought was interesting and really beneficial so that we can make sure that the practice continues to evolve with the needs of the community. These are the services that I would like to implement. Prenatal care that would focus on preventing preterm labor, so prenatal yoga and some support groups. Youth activities, which would teach and implement a healthy lifestyle, so activities, sporting events, support groups, healthy eating classes, and then STD prevention, testing, and treatment. School visits to provide education on STD prevention. And then postpartum support, which would have support groups and activities with other new moms in the area. So a lot of these services are not things that are covered by insurance typically, like the prenatal yoga or the youth activities, or there's still things that are unaffordable. So I decided for that reason to base the fees for services on the average income of the area, and then to provide packages that the patients can pay for monthly, which would include, you know, a general amount, a number of classes for that particular group. This is just sort of a breakdown of how I would envision the staff for the practice. We would have a collaborating physician, which is required in the state of Missouri, a nurse practitioner, a part-time nurse, activity and yoga instructors, and then a part-time counselor on site. And then I also have a volunteer program that I would have available to patients that they could receive free or reduced rate classes if they volunteer here as well. So the practice would be located downtown, just for easy accessibility for the patients. There'd be walk-in testing and STD testing and pregnancy tests, birth control prescriptions, and then the packages that I had mentioned previously. And here is kind of just the way that the nurse practitioner is so critical for this type of practice. So I really want to focus on prevention and education. So this type of population doesn't often receive the teaching or support that they need to reduce their healthcare risks due to lack of resources or lack of funding. So since this practice would have grant-funded support, then those without insurance or those that can't cover the remainder of those costs would be able to come in and access the care that they need. So these stats are kind of just reflections of the gaps that the nurse practitioner could fill with our focus on prevention and teaching. And then the budget sheets indicate a net income in year 1 to be $11,942, and then year 2 to be $17,463. Excel spreadsheets scare me, so this is very new to me. But the second year does reflect revenue with the addition of a second provider, another a full-time counselor, and then additional yoga instructors, so we could have more classes and more patients. The moral of the story, or sort of my end goal here, centers around the idea that as providers, we are quick to tell patients what they need to do to be healthy, but we are often so oblivious, in my experience, to the fact that certain parts of the area and certain parts of the population don't have the means to do what we're advising them to do. So we can tell them to eat healthy, but they might not know how to do that. We can tell them they need to protect themselves from STDs, but they might not have the money for condoms or the means to have themselves or their partners tested and treated. We can tell them to exercise, but they might not have somewhere to do that. And then we can tell patients till they're blue in the face that they need to reduce their stress levels and it's not good for their pregnancy, but they might not have a support system at home or access to stress reduction activities, so that's not always feasible. So the longer I've been a nurse, the more I'm kind of seeing that those that need it the most don't always have that access. So that is my goal with the practice. And then those are my resources.
Nicely done, Casey. And what an interesting idea.
Thank you.
I'll be curious to look at those scary Excel sheets. And
oh my goodness. I open Excel and I instantly get stressed.
Yeah.
I'm not a numbers person. My husband's an accountant, so he was like wanting to look at them and he's like, let me see. I'm like, no, I don't want to look at these any longer than I have to.
Yeah, so when we talk a little bit, I'm curious to hear about how much of it was actually grant income, because I mean, sadly, the healthcare system we're in, as you said, doesn't pay for the things that are going to, make somebody's health better. I mean, instead they'll pay for a premature baby,
exactly,
in the NICU,
which is far more expensive.
Yes, exactly. So, okay, good work, Casey.
Thank you.
Take a deep breath. You are done. Yeah, and go ahead and mute yourself.
Okay.
And let's move on to who was going to be next. Gab was going to be next.
All right. Can you guys hear and see me? Or see my...
Yep, we can see you. Yep, we can see you and we can hear you. So whenever you're ready, proceed.
All right. So again, my name is Gabriella, and I'm very excited to share my proposal with you. And I want to start my presentation with letting you know that this actually isn't just a project for my DNP here at Frontier. This is an actual addition to a program, or already program, that I've started working on within my hospital system. In fact, this class could not have come at a better time, because right when I needed help with the budget aspect, this assignment came up with the well-designed budget templates. So thank you to Frontier, and I encourage everyone to save those useful documents, however scary they may be. So our hospital system has a mobile caravan program. The picture you see in the PowerPoint is our actual unit. So we provide physicals, immunizations, lead and hemoglobin screenings, hearing vision screenings to children. We travel to schools and daycare centers within approximately 5 miles surrounding the hospital and provide these services completely free. We are currently 100% grant funded and work with approximately 80 to 100 sites every year. The mission of our program is that we believe children should have access to high quality care regardless of their ability to pay. We provide services, resources, and improve access to care. We believe in partnering with other organizations in the community to better serve our children and their families. And then our vision is that we will improve our community's health by reaching children regardless of financial barriers or access to care. Using our current caravan program model, I propose the following. First, we expand by adding midwives to provide sexual health services to teenagers and young adults. Second, we use the midwives from our hospital system who currently have clinic time available to be scheduled on the van 2 to 4 days a month. And third, we use this addition of midwives to trial billing and refer back to the hospital as much as possible. When looking at the county health rankings and roadmap, I found that Cook County, or Chicago, has worsening STI rates, increased number of children living in poverty, and more unemployment than previous years. As we all know, poverty and unemployment go hand in hand. I also reviewed the CDC's 2010 STI surveillance, which showed that Cook County, or Chicago, is number 2 in the nation for chlamydia and gonorrhea rates. We are just behind LA. Of all those cases, the majorities are in teens and young adults, which is our target population for this proposal. So we have had multiple conversations with partners in the community. First, Chicago Public Schools has approximately 400,000 children enrolled with strict rules and guidelines that we would need to follow. Chicago Department of Public Health has data on STI rates down to the school level, so they can tell us what their rates are for the individual schools. We also wanted to know where school-based health centers were located, as well as federally qualified health centers, to know who was providing sexual health services in the school setting. We certainly do not want to duplicate services. The University of Chicago has a sexual health team comprised of OBGYNs and researchers who are partnering with us for support and even potentially a study. On the ground level, school principals also need to be involved and identify particular needs of their students. These conversations helped me answer one question. What school has the highest STI rates within the Caravan service area that is not already receiving sexual health services? We identified one high school that's located 1.4 miles from our hospital system whose principal is on board. Also, recently, 1 day a week of my clinic time has been cut from the Caravan program and allocated to another mobile program. I would like to replace 1 day a week of my time with the midwives to help maintain our current patient volumes. I hope to start at 2 days a month with the midwives and to increase to approximately 3 to 4 days a month by the end of year 2. Again, I would like to trial billing during this time with the midwives who are already very comfortable with billing sexual health services and are willing to see boys and girls for sexual health needs. Our business model is going to be off of the Caravans program, which is under the hospital's 501c3. The goal is to provide these services and help offset the current $325,000 budget that is solely reimbursed through grant support. While we know the midwives won't cover a $325,000 loss, we hope to diversify our funding streams through insurance reimbursements. Currently, our grant funding is mostly from one funder. This funder also happens to be an older gentleman who is Catholic. Now, I'm not trying to get into stereotypes or a political debate, but it was definitely something to consider when we talk about providing sexual health services. We certainly did not want to upset our main funder. This meant we've had multiple conversations with him that started about 2 years ago with referring all girls of reproductive age to the midwives to answer questions about periods. It took time and building of that relationship to get to a point where we feel comfortable with piloting this project together. Because my time is shifting off of the Caravan budget, we will actually make money with the midwives totaling over $36,000 in 2 years. Now, I also want to share with you that without decreasing my time, my hours from the Caravan budget, this program would barely break even. This really surprised me. In conclusion, STI rates in teenagers living in Chicago is a huge problem. I propose to improve population health by adding midwives to our already successful Caravan program. This will provide more services, diversify funding, and trial billing on a smaller scale project. Thank you.
Fascinating. I think it's a brilliant idea.
Thank you.
Yeah, so good. I look forward to hearing a little bit more about it. I mean, it's really difficult to sustain a completely grant-funded, donor-funded nonprofit, for all the obvious reasons. So as clinicians, we have the ability to bill, and so I think doing a model that includes earned income, and that's sort of the term they used, earned income along with along with donations and grants is obviously more sustainable. So, all right, cool. Okay, thank you, Gab.
Thanks.
All right, so you may mute yourself. She muted herself so quick. I mean, I didn't even have to tell. I am on mute. Okay, next, Diane. So unmute yourself, please.
All right.
All right, and then go ahead and screen share.
All right. Of course, this is my Disruptive Innovator presentation. And I'd like to begin by saying disruptive innovation is something that all of us at Frontier know about because of our roots with Mary Breckenridge. She was known as a disruptive innovator before the term became trendy. It's a term used to describe a person capable of making an impact in their community. First begin with addressing what the community needs, and just a quick little snippet. I chose this background template because a disruptive innovator is one who is making waves in the community in a positive way. Currently doing clinicals at Merriam-Worthy's Women's Health Center. It serves the Albany, Georgia underserved rural area, operating as a nonprofit business 5013C. It's present along a known bus route for easier access for the public, and is also located beside a pharmacy for easy access to prescriptions that we can e-scribe during a visit. Our practice currently has 4 certified nurse midwives, 3 OBGYNs, 1 CNM who is leaving in April. And my clinical rotation at this FQHC has benefited me by allowing me to be training for my midwifery program and meeting requirements for Frontier for graduation, but also allowing me to be training for my new job, hopefully as the 4th certified nurse midwife at Merriam-Worthy. This is beneficial for this center because as soon as I complete all of my requirements for graduation and pass boards, I will already be trained for this midwife's role, which all of this training was of no cost to the facility. Saving money on training costs, allowing me to hit the ground running, seeing patients because I've already finished faculty-specific training. This specific site, because it's FQHC, does offer tuition reimbursement, training for medical students, nurse practitioners, as well as family practice residents. And it is owned by Phoebe Putney Memorial Hospital and operated by a board of directors from the local community. My statement of proposal is it's Women's Health Center is a nonprofit FQHC serving rural underserved women in the Albany, Georgia area. As a community health center, our mission is to provide comprehensive, continuous, coordinated services to all who access care by providing a broad range of maternity care as well as primary care options in our area, including the medically underinsured or uninsured. These services will be provided by midwives with excellent formal education, evidence-based care who are focused on women-centered physiologic birth. I propose to join this practice as a new midwife, taking the place of a seasoned midwife, leaving the practice during the same time that I should be finished with my clinical rotation. The summary of my community needs. I'm doing some research in the Albany area, and there were several needs that need to be addressed in the maternity care and primary care regions, which will benefit the entire community and improve the rate of adverse health and socioeconomic outcomes. Target areas of concern are the incidence of low birth weight infants, teen birth rate, and incidence of chlamydia in Dougherty County. Because of the high teen birth rates in Dougherty County, this directly contributes to the high rate of low birth weight infants in this area. The figures are over here on my little chart. Teens are at higher risk for seeking no or late prenatal care, anemia, gestational hypertension, and poor maternal weight gain. Preterm delivery is also more common with teens, directly contributing to the increased rate of these low birth weight infants. This is a concern due to the high risk of mortality, illness, and child developmental delay, and the cost that these burdens carry on our community. Evidence suggests that teen pregnancy significantly increases risk of repeat pregnancy and contracting STIs, both of which can result in adverse outcomes for mothers, children, families, and communities. The low birth weight infants of total births, 1,454 births out of a total of 10,943 births. Those 1,454 were low birth weight infants, which is a rate of about 13%, which is definitely higher than it should be. Our teen birth rates, the teen population is about 27,000, And of that population, 1,868 teen births occurred, making that teen birth rate 68 out of about 1,000 births. And then the chlamydia rates are 715 cases of chlamydia. These are all from the National Center for Health Statistics natality files. A vision of how APRN services will address these needs. Currently, our practice draws a few transfers of care at around 36 weeks from the Dougherty County Health Department, where a centering pregnancy program is in place. Centering pregnancy has appeared in literature multiple times because it has demonstrated a decreased risk of preterm birth. Traditional prenatal care has not demonstrated this benefit. My vision is to begin by volunteering with the Dougherty County Health Department Centering Program, encourage these women to come to our practice and make our practice known to them, and welcome these women as transfers to our practice. In doing this, continued education and excellent midwifery care should demonstrate a reduction in preterm birth. The more support and awareness in the community about this program will foster an environment of change for these communities' needs. Within all of my visits at the clinic, I will strive to provide adequate population-specific contraceptive and STI education in order to begin to decrease the rates of chlamydia in our population. The business structure, legal entity description. The legal structure, like I said before, is a nonprofit, federally qualified health center, which is run by a board of directors from surrounding 6 counties. By running this business as a nonprofit allows for grants and donations to be incorporated into the business model and improve the rate of success for the business. By incorporating local community members into the centralized management system governing the clinics, primary and maternity care is able to be delivered in a comprehensive, efficient, and cost-effective manner. Inclusion of community members allows them to give back to the underserved area as they know the most important areas of need which need addressing. By completing a community assessment, this also aids the board in making sure the clinic is meeting the requirements for the FQHC. The clinic can provide all of these services, meet FQHC needs and requirements, and begin to change teen birth rates, chlamydia rates, and low birth weight infants, as these are all interrelated concepts. Now, for the Excel spreadsheet portion of my budget review, I don't know if I did not estimate things appropriately or if this is really how it is. I would like to discuss that further with teacher. But for my clinical revenue year 1, total revenue was around $267,000, with my uncollectible revenue estimated around 5%. And total expenses were around $1.1 million with a loss of $611,000. Year 2 was a little better, with total revenue approximately $298,000, with uncollected revenue around 5% as well, and total expenses around just $1 million, with a loss of $428,000. So that's just a look into the numbers. And in conclusion, my plan is to join this existing practice, incorporate more patients into the existing centering program, transferring them into our practice. By increasing the number of patients in the centering pregnancy program, this will directly begin to decrease rates of low birth weight infants, preterm birth, teen pregnancy, and decrease chlamydia rates through education on safe sex practices and improved contraception options. The centering pregnancy model has been proven to reduce rates of preterm birth, which is growing in this Albany area, and the traditional prenatal care has not demonstrated this benefit. Thank you, everyone. These are my references.
All right. Thank you, Diane. That's an interesting idea to do outreach by going in and partnering with the health department that's already doing prenatal care, and I assume probably not doing birth. They're probably referring out for birth as a way to cultivate new patients.
Right.
And Yeah. So I think it's an idea that's worth, you know, really thinking through as, and we can talk a little bit more about that.
Okay, great. Thank you.
So it was a nice presentation. It you know, it was a little bit too long. You're gonna have to work on being concise, but your points were good, and I also look forward to seeing in your budget. Yeah, you can't keep losing that much money. That's not going to be. So, yeah, so we'll take a look at that. We'll take a look at that.
Okay, great. Thank you.
Oh, you're welcome, Diane. All right. So, Rachel, would you like to tell us what interesting idea you've come up with here?
Let me see if I can get back to screen sharing.
Okay.
Ooh, I don't know what that is.
That's pretty.
Ooh, something weird is going on.
Very nice pattern.
It's kind of crazy looking. Let me see.
Oh, there it's coming.
Okay, let's see here. Is it there?
Yeah. No, you're good. You're good. Yep. Yep.
All right. So, how do I get to the next slide? Okay. All right, I'm ready to begin.
Whenever you're ready, go ahead.
Okay. For my innovative presentation, I'm proposing that a full-scope, nonprofit, midwifery-led, freestanding birth center would be a great asset towards improving access and quality, cost-effective healthcare to vulnerable and underserved women in the Dallas, Texas metropolitan area. Community needs were assessed by reviewing data from the 2016 Dallas County Health Ranking Roadmap. In 2014, there were 39,806 births in Dallas County. Teen births in Dallas County in 2016 were 60 per 1,000 females ages 15 to 19, which was significantly higher than the state average of 52 per 1,000 females, and significantly higher than the US top performers at 19 per 1,000 females. Rates of sexually transmitted infection was another area of concern with Dallas, Texas, with Dallas County reporting 598.7 newly diagnosed cases of chlamydia per 100,000 of the population. This was also significantly higher than the US top performers of only 134.1 newly diagnosed cases per 100,000 of the population. Finally, 29% of the population ages 65, finally, 29% of the population under age 65 in Dallas County was found to be without health insurance, which is significantly higher than the US top performers at only 11%. These community health needs suggest that more cost-effective, accessible, and preventable healthcare services are needed, especially for the vulnerable and underserved population in Dallas. It is my belief that a midwifery-led birth center would be a great way to help meet these needs. Our mission at New Life Birth Center, which is the name of the birth center I'm proposing, is to provide full-scope, personalized, family-centered midwifery healthcare services to vulnerable and underserved women in a safe, trusting environment through the expertise of our highly skilled and compassionate caregivers. Our vision is to provide high-quality, cost-effective, accessible, safe, and reliable healthcare services to all clients every day utilizing the midwifery model of care. The proposed business structure is a 501c3 nonprofit organization, which will be controlled by a board of directors. As a nonprofit organization, the Birth Center will be able to receive donations, grants, and grants, which will help to support the mission of the center in caring for these vulnerable and underserved women in the area. So, which gets me to the plan. The plan for the Birth Center is to provide full scope midwifery service with physician consultation as needed. These services will include preconception care, prenatal care, labor support and delivery, postpartum care, initial newborn care, annual exam, STI screening, education and treatment, family planning, and we'll also see uncomplicated GYN problem visits as well, or problem patients as well. Utilization and revenue. The team of experts during the first year of operation will include three full-time CNM, one of which will serve as the clinical director, 2 part-time RNs, and 1 consulting OBGYN. Staff needs for the second year will be adjusted based on need. Utilization projection for year 1 is estimated at 230 clients, 180 of which will be enrolled for new OB based on a less than 1% projection from the number of births reported in 2014. And it was estimated that about 50 new clients will be seen for GYN and family planning during the first year. Projected revenue from grants, donations, and services during the first year is estimated at, or was calculated at, $178,805.77. Utilization projection for year 2 is estimated at 208 clients. Again, this was based on a less than 1% projection based on the number of births reported in 2014, with an estimated 75 GYN visits this year. Projected revenue from grants, donation, and services for year 2 is $383,840.09. Total expense projection for year 1 is $389,000. $389,418. And for year 2, the total expense projection is $510,388. It is projected that during year 1, the Birth Center will have a gain of $47,964.25, and a gain of $40,451.32 during year 2. In conclusion, based on the community assessment need, projected viability, and the addition, In conclusion, based on the community assessment need, projected viability, it is proposed that a freestanding birth center would be a great asset to the Dallas, Texas community by improving access to health care, providing effective costs, especially to these vulnerable or uninsured women, thus helping to decrease the disparity among teenage pregnancies and sexually transmitted diseases. This is my reference.
Excuse me, this won't stop. There, goodness. Thank you, Rachel. So there is a birth center in Dallas now, right? Or a couple, probably, right?
Yes, there are a few non-profit that I'm aware of. And there's a lot of patients, because as you see, the birth rate is high. And even currently at the hospital where I'm working, sometimes these women without insurance are waiting up to 6 weeks or more sometimes to get in to have their first new OB visit.
Right. Yeah, I jotted down 29% uninsured. I mean, that's really, really high. And that's with the Affordable Care Act in place. I mean, we're not going to spend a whole lot of time talking about politics here today, but I mean, the uncertainties of what's going to happen in the next, 6 months, makes it all the more important that we have creative solutions and be ready to be responsive to try and figure out how to take care of needs. Yeah. Great, Rachel. I'm all about birth centers. I would love it if you actually pursue this. And we're going to talk a little bit later. I mean, we know that Gab is seriously looking at this project in Chicago. But my question for all of you after we take our break, after Susie's presents, is how many of you are seriously looking at these things? But first, let's hear from Susie. So Rachel, go ahead and mute yourself.
Okay.
And Susie, unmute yourself. And pull up your screen share.
Maybe I better go to screen share. Share screen. Let me get my PowerPoint up.
We're seeing it, so that was good.
Well, we've got that part, and now I'm just trying to find a little thing on this one because I had not practiced doing it with the Apple. I just was going to have it on the side, so I'm not quite sure how to minimize these things on the side. Are you okay if I just click through?
Well, let's see. How can you, go back up there.
The top up there, Susie. Kind of
what now?
Top
Nope.
To the right, it says present.
Right to the yeah. Oh, like that. Oh, how cool! Thank you. Awesome. Yeah, I was really worried when I heard IT was not going to be hanging on. I guess I didn't need to worry. Thank you so much. Okay, so as you see, my name is Susie Wolfenden. My plan is to work at Peace Medical Clinic in Lakeside, Arizona, with an MD and an NP who has been practicing the NP has been practicing for 8 years there. Starting salary, according to things that I've looked up, my references on the side, the association, is $90,956. The Association of Nurse Practitioners estimated that new practitioners see about 3 to 4 patients per hour. My proposal is to assist in bringing the CDC's National Diabetes Prevention Program to the neighboring tribe 6 miles away with the hope of fostering prevention programs in each of the main 13 White Mountain Apache communities. The White Mountain Apache tribe, located in parts of Navajo, Apache, and Gila County, Arizona, had a 2010 population of 15,492. Now, some of these comparisons will be using statistics from the reservation as well as the county. Comparison of education employment data place it below Arizona and U.S. levels. Only 445 out of the 15,000 plus people on the reservation had bachelor's or higher education. In 2010, the employment rate was 41.1, but by 2013 had improved to 11.3 on the tribal lands. But Arizona was 6.9 in 2013. The 3 top issues for health are obesity, which it's a pre-diabetic state, particularly in Native Americans. The rates are 31%. Number 2, diabetes rates are 34% of men and 36% of women. And number 3, sexually transmitted diseases, particularly chlamydia, is in Navajo County is 865 per 100,000 compared to 465 in Arizona per 100,000 and 134, as we all mentioned, in the top performing states. Obesity, a precursor to diabetes, heart disease, and mental health issues, affects 31% of the White Mountain Apache tribe. Factors increasing obesity are the Food Environment Index, which includes the healthy foods, and the food insecurity indexes and close access to a grocery store, is 3.9% in Navajo County. It's 6.8% in Arizona and 8.3% in the U.S. Exercise opportunities are only at 47% in Navajo County and 86% in Arizona and 91% in the U.S. Children in poverty is 35% in Navajo County, 26% in Arizona, and 13% in the U.S. Physical inactivity is 24% in Navajo County and 21% in Arizona and 20% in the U.S. Diabetes is one of the most prevalent health concerns, afflicting 13.9% of the White Mountain tribe in 2013. CDC estimates diabetes costs $13,700 per person annually. My vision is that that rate will be cut below 50%. The CDC Diabetes Prevention Program is the CDC's #1 proven method to decrease the risk from type 2 diabetes by 50%. According to the CDC, in 2016, there were no prediabetes prevention programs in northeastern Arizona. A model diabetes prevention project among 80 tribes in other parts of the U.S. using culturally sensitive modifications showed that those who participated in the program had improvements in their lipid profiles, blood pressure, weight, and a lower rate of diabetes after the program. A rate of 4% of conversion of onset diabetes compared to those who did not, 7 to 12% in the control group. Even the early dropouts from the study improved their diabetes rate to 4.9%. In the diabetes prevention program, for the first 6 months, you eat healthy without giving up all of the foods you love. You add physical activity to your life even if you don't think you have time. You're taught to deal with stress. You're taught how to cope with challenges that can derail your hard work, like how to choose healthy food when eating out. And you're helped to understand how to get back on track if you stray from your plan, because everyone slips now and then. I really liked this program because it looked a lot like the centering program, but this made a lot more sense for this particular population. The APRN role will be fulfilled but through work on health promotion, disease prevention, and health protection, including fostering collaboration with multiple stakeholders by attending tribal meetings, identifying supporters there, considering a tribal resolution of support with those supporters, and gaining the support of the medical and clinical staff in the reservation. And with those stakeholders to identify the need, assess the need, identify the barriers, and encourage the community partners to send referrals to the program, and then to recruit graduates to mentor. Costs and opportunities. Permanent lifestyle changes require a year. So they have weekly meetings for 6 months and monthly for 6 months. And these are the costs: library rental, library room rental, healthy food from the tribal farm when it's in season, and that's provided at cost by the tribe. And then paper goods and utensils, bariatric scale, a blood pressure cuff, The CDC program provides $500 per person. And again, we use culturally modified materials such as keeping track journals. We have speakers and coaches from time to time, but the majority of the program, a lot of it is facilitating the one-on-one contact and the interaction one with another as they encourage and support one another. The big problem, the big barrier, are transportation. This is a 1.7 million acre tribal with tribal lands, and the altitude, it ranges from 2,500 feet to over 11,000 feet. So you can see that transportation is a problem. And currently there's only a Medicaid transport for dialysis. Onward, there is no conclusion, nor can there be. The needs are too great and we're too few. APRNs must press on and never give up. And that's it.
Thank you. So Susie, are you feeling emotional?
Oh yeah.
And what's that about?
It just matters so much to me. I really do want that rate to drop.
Yeah, yeah.
And my plan might actually be to work at White River Hospital, but my backup plan would be to be at one of the local nurse practitioner, because we don't have to have a doc. So I was a little surprised that the nurse practitioner was there with him, but that's fine. He started the practice, he can be there.
So I was a little bit unclear in your presentation. So there is an existing clinic, this White River Apache clinic, that what you're proposing is adding this this toolkit and this plan, like this group care for people with diabetes. Is that what you're suggesting?
No, it's treatment for pre-diabetes. It's to prevent those. And so what the studies found is here in the States.
You know what, Susie? You know, let's not get into the rationale for it. I just wanted to be so. I wasn't clear in your presentation. What is it that you're adding yourself? You're proposing that they hire you to do this program. Is that what your proposal is?
No, I would volunteer to do the program. This would be a mission.
Okay. Okay. Because you have that passion that we got to feel in our hearts. Yeah. All right. Okay. Got it. All right. So I think in the very beginning, so before, you know, we're going to break in a second, but it's real important in the beginning of each of your presentations to be very clear about what it is you're doing. It's easy to jump into data, but for your audience, you know, you have to think, hey, somebody's listening. You may have all these ideas about what you want to do, and you know perfectly well what you want to do, but your audience doesn't have a clue. So for all of you to start your presentation saying, this is what I want to do, and then go on to why and the rationale and all that stuff. So, okay, so you have all succeeded in doing your presentations. They're all very interesting. What I find most interesting is that all 5 of them are in the nonprofit world. None of them in the for-profit world. Isn't that interesting? Yeah, yeah. So so let's take, okay, so it's a little after 4. Let's take like 3 or 4 minutes, okay? And you guys get up and stretch and have a glass of water, do whatever you want, and then we'll gather back together and we'll talk, okay? Be back in a minute too. Well, I guess I could stop recording.